In this lecture, we're going to be talking about the concept of mobility. Mobility in nursing practice is going to be taken primarily from, again, our Tim B's Medical Surge introductory book. Chapter 37 is caring for the client with central and peripheral nervous system disorders, but we're going to specifically look at a couple of disorders. The first type being neuromuscular disorders on page 617, and the lecture in general will be taken from chapter 37. Just looking at the mobility assessment framework again, just as a reminder, musculoskeletal evaluation, we're going to look at muscle strength, joint, range of motion, structural integrity. This should all be hopefully a refresher from 108. Neurological assessment, again, we're going to assess nerve functions, reflexes, coordination, level of conscious alertness, etc. Assistive devices, we're going to determine the need, back to looking at mobility, need for walkers, canes, wheelchairs, or any other assistive devices. Diagnostic testing, when we're looking at mobility specific to neurological complications or neurological disorders, we're going to look at an EMG, EEG. We also may get an X-ray, CT, or MRI. More than likely will be a CT or an MRI for a more specific picture where with more detail. And then laboratory will be disease specific. Just again, thinking about core nursing interventions for impaired mobility, kind of regardless of the disease process, safety is going to be priority. If it's neuromuscular degenerative diseases and disorders, of course, we're always going to look at preventing falls and injuries, maybe environmental modifications, again, assistive devices, what kind of equipment do they need, and education on proper use. Looking at skin integrity, I know we talked about some other issues when it comes to skin integrity, but we're going to obviously monitor for pressure injuries and breakdown, especially as clients have poor mobility and maybe sitting in same positions longer or having the inability to move themselves. So hopefully this is all just tied together from what we've talked about in 108, but just remember pulling it back in because the fundamentals will always apply. Medical management, we're going to administer prescribed medications as ordered, and then promoting independence, we're going to encourage self-care within patient capabilities. All right, the first one that we're going to talk about is multiple sclerosis. Multiple sclerosis is a chronic progressive disease of the peripheral nerves. It's onset in young adulthood and early middle age. The incidence is actually greatest between 20 and 40 years of age, and it affects men and women approximately equally. It is more common in northern temperate zones than in warm climates. It's considered an autoimmune disease. Researchers believe it's triggered by defective genes. Studies show that it's associated with inflammation that infects genes that are involved in controlling the immune system. Other research has shown a link between a distorted gene that causes a vitamin D deficiency in MS, but it's characterized by a demyelinating disease. Again, demyelinating disease because it's permanent degeneration and destruction of myelin. That myelin, if you need to, there's a kind of a picture here, but if you recall, it is an insulator that enables nerve impulses to pass along the nerve fiber. And basically that insulation eventually kind of starts to degenerate off, and so the nerve impulses cannot pass through. So, loss of myelin and subsequent degeneration and atrophy of those nerve axons interrupts the transmission and impulses along those fibers. Many clients experience gradual and continuous worsening of their symptoms. So, it's kind of a progressive degenerative disease. They have the disease in a mild form and don't experience, any severe symptoms for some. Symptoms subside during the early phases and they end up in remission. Clients seem healthy for several months or even years. There can be reappearance and exacerbations as with any autoimmune disease. Symptoms become more severe and last longer. Infections and emotional upsets precipitate exacerbations. So some people can live a long time with MS, and survival 20 years after the diagnosis isn't unusual. So that's meaning that it's common. As the disease progresses, many complications such as pressure ulcers, cachexia, meaning they're really, really thin and skinny. You can see the ribs and just kind of a muscle wasting type of skinny. Deformities and contractures develop. They can get pneumonia brought on by limited activity, shallow breathing, or just general overall debility. Often the immediate cause of death is respiratory issues, based on that progressive worsening debility. Um, Assessments of multiple sclerosis and that clinical presentation. Typically, the signs and symptoms, a lot of times, many clients first dismiss those minor symptoms as a result of just fatigue or strain. But then, when they those progress, they may report blurred vision, double vision, nystagmus, involuntary movement of the eyeball, is a key clinical finding with multiple sclerosis. An intention tremor, slurred, hesitant speech may develop depending, and again, this is one of those, it depends on which part of the brain is affected where you may see your symptoms. Weakness of arms or leg can progress to ataxia, so they have poor coordination. They could even get paralysis. I know recently I was caring for a client who's in a long-term care facility due to multiple sclerosis, and she is no longer able to utilize her legs at all, and she has some contractures in one of her arms, but she absolutely had paraplegia as a result of her multiple sclerosis. They can have bowel or bladder incontinence. Visual disturbances can also end in blindness. Illness can impair intellectual functioning, latent cores, and loss of memory, difficulty concentrating, and impaired judgment can occur. I actually have a family member who was diagnosed with multiple sclerosis, and this was actually their primary symptoms were memory loss, difficulty concentrating, and impaired kind of processing mentally. It almost kind of looked more like a dementia, which was a very rare form of an initial presentation of multiple sclerosis, but it does happen. Diagnostic findings we talk about here. Early diagnosis is difficult because those symptoms are vague and in some cases temporary. So typically it's a lumbar puncture with CSF analysis. There may be an increased white blood cell count. Then they'll look kind of further test the CSF fluid and look for like proteins and immunoglobulins and stuff like that. So basically lumbar puncture, and then they also will look at a CT scan or MRI to look for lesions in the brain's white matter. Medical management for multiple sclerosis. What we are going to look at, there's not really any single treatment, so we're not going to pull out any specific medications for multiple sclerosis, but definitely nursing management. You're going to assist the client and just any needs that they may have. If they have visual problems, all of our interventions are going to be based around their manifestations of the disease. So the client may be, have slower speech and harder to understand, so they may need adaptive devices, that kind of thing. If ambulation, of course, is impaired, they may need a wheelchair or walker, whatever is most appropriate for the patient. The nurse may also look at, if there's issues with bowel motility and stuff as a result of the disease. They may look at high fiber food and increased fluids. And then they may eventually need like intermittent catheterization for bladder elimination. And then just looking at, what would be some suggestions for interventions for their diet. We're going to look at increased protein intake. They may need semi-solid foods just due to impaired swallowing. And then eventually they may need G-tube feedings if they can have long-term effects. Okay, our next disease process is myasthenia gravis. It's also a neuromuscular disorder characterized by severe weakness, one or more groups of skeletal muscles. It's more common in women, but it can affect both genders, and the onset typically occurs during the young adult years. It's also unknown as far as its exact etiology or cause, but it is believed to be autoimmune in nature. It develops when antibodies produced by the thymus gland bind to basically degrade acetylcholine receptors on skeletal muscles. And so the outcome is that they have severe extreme muscle weakness during the exacerbations of the disease. And basically when they are they have exacerbations with activity, and then they have strength that's restored with rest. So one of the key, obviously for any of these disease processes is to, encourage periods of rest for them, as it can cause exacerbations or just increased manifestation of symptoms. So there is a little thing in your book. It's just kind of a neat little picture of like acetylcholine and like the nerve endings and the receptors, and kind of just where the antibodies for are blocked for myasthenia gravis, just if you need like a kind of a pictorial. But it basically muscle weakness. Let me go on to the next slide. Sorry. So for myasthenia gravis, muscle weakness, basically you will see maybe drooping of the eyelids, so that is called ptosis, ptosis. They may also develop difficulty chewing and swallowing. They also may have double vision or a weakened voice. They may have a mask-like face expression just because they can't, they have that drooping of the eyelids, so they're have some difficulty with the muscles in the face, and they are not able to, you know, so they have like a mask-like face expression. I think that's hopefully self-explanatory. But during a myasthenic crisis, they experience increased muscle weakness. They can have respiratory distress, decreased tidal volume, meaning that they can't take in deep breaths. So their lung capacity is lower. They may have difficulty talking, swallowing, and chewing. As far as diagnostics for myasthenia gravis, it's made by confirmation of IV administration of tinsolin, but it basically relieves the muscular weakness for a few seconds. So basically that would dissipate in about 5 minutes. And so it's kind of like, if this medication works, then we can kind of see that that's a confirmation for diagnostics for myasthenia gravis. They may also do like a chest CT to look to see if the thymus is enlarged, or they may do the EMG to look at the electrical activity of the muscles and how much potential they have. Basically, it's just like an EKG for the heart, an EEG for the brain, an EMG is for the muscles. Medical and surgical management, we're going to try to facilitate normal neurotransmission. So they're going to take anti-cholinesterase drugs. We're not going to really study those in this area, but just know they may be on your pharmacology thing later. But basically, it prolongs the action of acetylcholine, which helps sustain muscle contraction. So, and that dose of the drug is adjusted for the client's response. Nursing interventions, we're going to provide periods of rest, restoration of strength, supporting ventilation, of course, simple, elevating the head of the bed, making sure that they have suction. If they have any difficulty swallowing, we're going to offer them, be patient in their areas of communication if they're having to be longer in their speech, but also maybe give them a communication board if it's easier for them. Effects of the drug therapy may observed, especially when it's initiated at the time of stress. So sometimes we may administer medications to maintain therapeutic levels so that they kind of don't have that waxing and waning from the medication wearing off. But obviously we're going to observe for any adverse effects from the medications. But again, we're not going to focus on those for myasthenia gravis either. But again, it's the anti-cholinesterase medications. And it does talk about cholinergic crisis. And that cholinergic crisis is the over-medication. So they may have abdominal pain, nausea, vomiting, blurred vision, pallor, facial twitching, or hypotension or bronchospasm. So basically, we're trying to help with that medication elevate their muscles contractility. And if they have too much of it, then all of that's going to be, even to the excess. So we would obviously, for an intervention in a cholinergic crisis, though, we would absolutely withhold the medication. And then, of course, we give atropine. But I think, key interventions, if somebody's in a cholinergic crisis, we're going to withhold the medication. But if they're in a myasthenic crisis, again, that's an acute exacerbation of the disease. signs of a myasthenic crisis is that they have an increased heart rate, increased respirations, blood pressure, shortness of breath, and incontinence. And then the intervention is going to be increase the anticholinesterase medication as prescribed. So, but obviously, ABCs, if they're having any difficulty breathing, we're going to, again, raise the head of the bed and do interventions for their breathing first. And then we would look at, obviously giving the medication, but, airway first. And then we're going to get an order or give a dose that we have of the anticholinesterase medication as is prescribed. Okay, our last disease process that we're going to look at in the mobility with neurologic disorders is an extrapyramidal disorder. And I hope you've probably heard this because we just got done talking about mental health, but extrapyramidal disorders have an origin in the motor cortex, but they basically surround areas of the cerebellum and the basal ganglia. So, Parkinson's disease is an extrapyramidal disorder as well as Huntington's disease. And the primary characteristics is abnormal movement. So, when they talk about EP, extrapyramidal symptoms, when medications, especially neurological medications, are like side effects or adverse effects, so like that tardive dyskinesia, stuff like that. So when we think about that, if we can kind of tie that together in our brain with extrapyramidal disorders or extrapyramidal symptoms when it comes to medications, it's that Parkinson's like. So I think we may all have had experience of seeing or having even a loved one that had maybe Parkinson's disease, but those tremors and the even famous like Michael J. Fox, that is somebody with Parkinson's disease. So that, basically kind of spastic, abnormal muscular movements that they are unable to control. So Parkinson's disease is a degenerative disease, usually begins after about the age of 50. It primarily affects the basal ganglia and connections in the basically substantia nigra and corpus stratum. The term Parkinsonism is used to describe a cluster of symptoms that develop from several etiologies. So there is a little picture in your, again, book if you're visual and need to kind of see what part of the brain is affected, but I will move on. And again, it says here, risk factors, male gender, over the age of 50, there's a genetic link, exposure to toxins, or a chronic antipsychotic use. Again, so that same thing, you'll see those same symptoms, whether they are related to just the general disease process or related to medications. And either way, it can lead to the diagnosis of Parkinson's. Parkinson's disease and Parkinsonism result in a deficiency of the neurotransmitter dopamine, which is huge. So we will look at one medication when it comes to Parkinson's, and that's going to be carbidopa-levodopa. Again, so the neurotransmitter dopamine is the deficiency. So in the absence of dopamine, another area of the brain basically responds to acetylcholine and it just becomes overreactive. And that imbalance between dopamine and acetylcholine results in movement disorders that characterizes Parkinson's disease. In most cases, no cause can be found for the dopamine depletion. Symptoms have been associated with, like, again, social, environmental toxins, insecticides, herbicides, kind of things like that. But they're not 100% for sure. But the symptoms can also occur as chronic traumatic encephalopathy from repeated blows to the head and encephalitis. So whether somebody had an infection in the brain or, maybe you're looking at, somebody that plays contact sports and has had repeated or even just unfortunately maybe been in situations where they've had repeated head trauma, like in the, with Muhammad Ali. Basically, there's a category, the phenthozines is another antipsychotic medication that can be used to treat schizophrenia, and that can cause Parkinsonism. Manifestations progress slowly, that years kind of can elapse between those first symptoms and the diagnosis. The symptoms are usually unilateral, but eventually will become bilateral. So those four kind of cardinal signs for Parkinson's early may actually be stiffness and rigidity. But then kind of a pill rolling tremor in the circular movement of the fingers and the wrist, kind of like you're manipulating a small object or a pill within your palm, in one or both of your hands. That hand tremor is obvious, and rest typically decreases. But when the movement is voluntary, the hand tremor is obvious and typically decreases when the movement is voluntary. So basically, it's an involuntary movement at rest. But when I try to make a voluntary movement, such as picking up something, again, it will decrease. And again, so that's that resting tremor. And then bradykinesia. So thinking about kinesia, that's my muscle movement. What am I doing? So there's bradykinesia, the slowness in performing spontaneous movement. So I may have a mask-like expression again. The clients may have a stooped posture, low volume of speech, and also then could progress to difficulty swallowing. They can also have a weight loss as a result. Shuffling gait is also pretty classic with Parkinson's, and the client has a difficulty in turning or redirecting or being intentional in turning them around. And then postural instability, that impaired balance and coordination. So again, you'll see those as listed here as those four cardinal signs: tremors, rigidity, akinesia, and then postural instability. So of course, we're thinking about safety measures. We're going to do a neuro assessment. We're going to provide high calorie, high protein, fiber meals with small frequent feedings, and increase fluid intake, promote independence. So we may be looking at, again, so complications for aspiration, memory deficits, UTI, depression, and skin breakdown. So a safety intervention may be something as simple as giving that client a cane or a walker to help them with their physical instability. Medical management, we are going to look at carbidopa-levodopa. It is a classic anti-Parkinson agent. The pharmacological class, however, is dopaminergic drug. The mechanism of action, it basically, levodopa is converted to dopamine in the brain and then replaces the depleted neurotransmitter stores. Carbidopa prevents the peripheral conversion of levodopa to dopamine. So basically, it allows more levodopa to cross the blood-brain barrier. So basically, that combination is so that the carbidopa can help the uptake of levodopa across the blood-brain barrier. Side effects of carbidopa-levodopa is lightheadedness, dizziness, insomnia, confusion, nausea, constipation, dry mouth, and orthostatic hypotension. Things that we want to teach our client: to take it as prescribed. Do not stop it abruptly because it can cause a Parkinsonian crisis. Do not take with MAOIs that are often prescribed for depression. And don't take with foods high in protein as it affects medication absorption. So obviously, taking it with just water in the morning, it's usually given early by itself. If they needed to, if they had nausea or needed to take it with some food, give it to them with something like, something bland, something with like applesauce, like they would normally take their medication, but not something high in protein. All right, let's test your knowledge. NCLEX practice question. The nurse is caring for a client who has myasthenia gravis. Which of the following is a complication of myasthenia gravis for which the nurse should monitor? A, confusion; B, increased intracranial pressure; C, joint pain; or D, respiratory difficulty. You can pause here if you need to. I'm going to go on to the answer. And the answer is C, respiratory difficulty. With myasthenia gravis, progressive weakness of the diaphragm and intercostal muscles can cause respiratory distress.